Um, so today, as Dr. Abdurrahman said, we'll talk about mechanical power. Sorry about the slides. This is from like different lecture I'm doing on the same topic, so it might have like, kind of different style. But so let's talk about what is mechanical power, how do we measure it or calculate it, and why do we even bother with that term mechanical power? I don't have any financial disclosures to share about that topic. So we'll quickly go through before we talk about power exactly what is the definition of energy and what's the definition of power, how to calculate mechanical power, why is mechanical power important and its relation to ventilator-induced lung injury. Then we'll go a little bit deeper, not just the total mechanical power, we'll go into transpulmonary mechanical power and transalveolar mechanical power. And we can talk about a little bit research being done on mechanical power and more questions to be answered about that topic. So ventilator-induced lung injury, as we all know, it can be adverse consequences of mechanical ventilation. It's very hard to really quantify how many of our patients have ventilator-induced lung injury because there is so many forms of lung injury, and we don't have a gold standard to diagnose them. But there's many implications, ventilator-induced lung injury. The ones that we usually talk about is alveolar stress related to the applied pressures, the driving pressures, strain usually related to the volumes. So now the whole idea of mechanical power that we're combining not only barotrauma or volutrauma or atelectotrauma, we're combining all the factors that can cause ventilator-induced lung injury into one formula, and it's the mechanical power.
Please, Dr. Ehab, can you maximize the screen?
I'll maximize it. Yes. If I can know how to do that, I will.
Press F5 button on keyboard. The slide or F5 key button.
Oh, okay. Is that better? Is that a little bit better?
Yes, it's better. And if you can also maximize the screen, yes, this is very good.
Okay, okay. Yeah, so again, we'll talk about the power, but more importantly, also, I think it's very important, and it's very few literature talking about that, is indexing the power. So when we calculate the mechanical power, and you will find some studies saying, say more than 15 joules per minute is dangerous, more than 17 joules per minute is dangerous. I think the mechanical power should be indexed to a certain area, meaning to the compliance, because not all the mechanical power, if all of us getting 15 joules per minute, but somebody has bad compliance ARDS, one has a good compliance, I don't think the injury will be the same. And as I told you, there's few studies talking about that. The idea of indexing the power is interesting, trying how static and dynamic parameters contribute to ventilator-induced lung injury. The whole mechanical power is the amount of energy transferred from the ventilator to the respiratory system per unit time. And we'll talk about this in a little bit in more details. And mechanical power depicts the energy transferred to the whole respiratory system by the ventilator during certain time. So mechanical power usually is referred to joules per minute. Let's take a step back a little bit and talk about the physiology and mechanisms of mechanical ventilation. There's various topics, as mentioned before, can be accounted for injuring the lung. And it used to be always the debate or the fight between clinicians is what injures the lung? Is it the tidal volume? And people who believe in the very low tidal volume, they will tell you, nope, it's only the volume. So that's why 4 to 6 milliliter per kg. Some other people would say, no, it's the stress or the pressure applied to the lung. So try to minimize the driving pressure. But now we understand that even the inspiratory flow could affect the ventilator-induced lung injury. Something like even simple as the respiratory rate can affect the lung injury. And I like to think about the respiratory rate like as if you're two in a boxing match. And if you get punched 10 times per minute, maybe you can last 10 rounds. But if you get punched 20 times per minute, you might last 5 rounds. And if you get punched like 30 times, you might last for two rounds. So the more the ventilator gives the inner energy to the lung, which is the respiratory rate, how many times per minute, can really affect the ventilator-induced lung injury. And when you see in the calculation, you would find that the respiratory rate alone is very closely related to the mechanical power. So something simple as reducing the respiratory rate might affect the mechanical power. And if you remember in the low tidal volume ARMA trial, the 6 milliliter per kg tidal volume, we all found that the patient gets really having respiratory acidosis. So we tend up to increase the respiratory rate to compensate for the minute ventilation. And that is kind of dangerous. So the goal of mechanical power is, again, as we said, it's the energy delivered from the ventilator per minute, and it incorporates all the components derived from the ventilator, like the tidal volume, the inspiratory flow, the pressure, inspiratory time, the PEEP level, the respiratory rate to optimize outcome. So what is energy? Energy is basically calculated as meaning work. And we all know that when we try to calculate the work of breathing on the patient, and is depicted in joules. The definition of work in physics is force times displacement. And by force in the ventilator, it will be the pressure, how much pressure the ventilator is giving, and the displacement will be the tidal volume. So it's basically pressure times volume. When we divide those by minute, we get to the mechanical power. So mechanical power will be the energy per time, pressure times volume over minute, per minute. When you think about it, how do we calculate this? We all know about the pressure volume curve that we measure in the mechanical ventilation. So if you calculate the area under the curve of the pressure and the volume curve and divided by minute, that's your mechanical power. So usually that's the most common equation for mechanical power. 0.098 is just a conversion unit multiplied by the respiratory rate, how many times per minute, multiplied by the pressure in centimeter water, multiplied by the tidal volume in liters. Mechanical power coming from the equation of motion. And I always talk to the residents and the junior faculty, you would not understand mechanical ventilation if you don't understand the equation of motion. What does the equation of motion tell us? It's how much pressure is required is elastic pressure plus resistive pressure plus peak pressure. Again, P mass plus P vent equal P elastic, P resistive plus P total. So how do we convert the elastic pressure? What is the definition? We know that elastance, the pressure equal elastance over volume. and pressure against resistance. Pressure is resistance times volume plus peak. Again, I'm not going to dwell too much on it, but this is, again, the equation of motion that the mechanical power equation is derived from. Okay, so what are, again, the ventilator-related factors of mechanical power? As we talked in the previous one, it's include the tidal volume, the pressures, the flow, the PEEP, and the respiratory rate, and they all interact together to give you the mechanical power. And of course, of the forms of ventilator-induced lung injury that we know, the barotrauma, atelectotrauma, volutrauma, the new terms ergotrauma, biotrauma, rheotrauma. So there's so many forms of, again, of ventilator-induced lung injury, but we have to be careful about what can we modulate on the ventilator to reduce that ventilator-induced lung injury. Okay, this is actually, I like, let me just, sorry. Okay, the components of work. Because it became more complicated, actually, it's not only we're looking at one equation or mechanical power, we're looking for a lot of things here. So let's go to this figures, this picture here. This is the volume pressure curve in a volume control mode on the left. And as you can see, according to how bad the compliance or the elastance, we're starting from 0. And as soon as we hit like that, we used to call the low inflection point, you start having that linear relationship between the volume and the pressure. So that looks like the volume pressure curve on the volume controlled mode. And those patients are passive, so they're not having any work. If you look at the right side here, that's the right picture. Now, this is the same pressure volume controlled, but on pressure controlled mode. So we know that the pressure controlled mode gives the square pressure waveform versus the volume controlled, it gives almost like a triangular shape airway pressure wave. So according to those shapes, we can divide actually the work into static elastic work, which is including the work to overcome the PEEP and the tidal work here in the blue triangle, and also to overcome the resistive work. If you look again on the right, same idea, elastic work, that blue triangle here. It's the elastic part to overcome the PEEP and the tidal work. And on the right here, the resistive. So just by looking between the curves on the volume controlled modes here on the left and on the pressure controlled mode, you can see that this, for the same volume, same pressures, same tidal volumes, same airway pressures, the area under the curve in pressure controlled modes is bigger. So immediately we know that pressure controlled modes give higher mechanical power than volume controlled modes. So let's go about what I was talking about here. What is resistive work? Resistive work, as it implies, it's the work dissipated as heat to generate flow through the airway resistance. So it's basically the work needed to overcome resistance. How about elastic work? Again, same. Work needed to expand the lungs and the chest wall. So basically to overcome the elasticity of the whole respiratory system. Now the elastic work, you can divide it to make things more complicated, you can divide it into PEEP. And PEEP, we call it static elastance because it does not change from a breath to breath. So PEEP work is the work against PEEP during inspiration, which is temporarily stored as energy in the elastic tissue. Because again, the PEEP is there during inspiration and the airway pressure is above it. And during exhalation, the PEEP is still sitting there. Tidal work is the whole work minus the PEEP work. So it's basically how much work or how much energy the ventilator gives the lung during each tidal volume. And then the added inspiratory work will be the sum of the tidal work and the resistive work. And of course, the total work is the work generated by the ventilator to its a whole area to deliver to the respiratory system. I want to tell you, like, if you want to have any questions or if you want to stop me or have any comments, please feel free. Don't be shy, okay? If it's get too much or if I talk too fast, yeah, please just pause me. So we'll go again to the same, almost the same pressures, same figures in the last one that we're talking about. Again, this is in a volume controlled mode, the volume versus the pressure. And here we have the beginning of the work. So this is the PEEP work. This is the tidal volume. In this part is the tidal work and the resistive work. And we all know in the volume controlled mode, it looks like, again, a triangle, the peak pressure, if you put a plateau. So it basically compares to you like the shape of the airway versus the whole idea of inspiratory work. So each breath, you will have tidal work, resistive work, and PEEP work. Same in pressure controlled mode, the PEEP here in blue, the tidal volume here again in blue triangle. So those both are called the elastic, and the yellow one is the resistive. And again, we can see the difference between pressure control, volume control. This is somebody who's having unassisted ventilation, meaning having spontaneous breathing. So you can see that having the sinusoidal flow breathing way, and you can compare the resistive work and elastic work. There is no PEEP work here because the patient is unassisted breathing. Why is this important? Why don't we just talk about total mechanical power and that's it? Why are we making it complicated? PEEP work, tidal work, resistive work? Because we are still not sure which work or which energy can injure the lung. There's a big debate still. Does PEEP, like the amount of energy, does it worsen? Can it contribute to lung injury? Maybe, we're not sure. Does the tidal volume, every tidal energy worsen can contribute to ventilator-induced lung injury? The answer is probably yes. Another big question is, does resistance worsen the lung injury? Meaning, if you have to go up on the pressure in somebody with high resistance to just pass the air into the lung, does that matter really? This is just heat, and this pressures, our alveoli does not see it. All these pressures to overcome the resistance in the airway. So does this worsen ventilator lung injury? Again, we don't have much literature about that. Okay, so let's go on how to calculate the mechanical power. And I'm sure you all know about the original calculations by Gattinoni and Becher. And of course, each mode has to have a different way of calculating the mechanical power, volume control versus pressure control. But it's simple because it's basically, as we talked before, it's a volume times the pressure times the respiratory rate times the conversion factor. So that conversion factor on the right is pretty similar. So Gattinoni said in his initial article back in 2016, he made the calculation is, so tidal volume, the change in volume, and to include all the elastic static component, elastic dynamic component, and the resistive component, he came up with this formula. Peak pressure minus the plateau pressure minus PEEP divided by 20. People thought it might be a little bit complicated. So after a year or two, Giosa did this article and another calculation. And again, same idea, delta volume, change in volume, multiplied by the peak pressure plus PEEP plus the frequency, plus the flow over 6, all divided by 20. Multiplied by the respiratory rate, again multiplied by the conversion factor. So this is supposed to be a little bit simpler than the initial calculation or formula by Gattinoni. Now in pressure controlled, Becher and his colleagues, they did two articles about that. one kind of complicated one and one simplified equation. But again, the same, change of volume multiplied by PEEP. Here they did the inspiratory pressure multiplied by 1 minus elastance to the power of inspiratory time over time, which is super complicated. Of course, I would never try to calculate that at the bedside. So they said for simple people, okay, change of tidal volume multiplied by pressure times the inspiratory pressure times respiratory rate times the conversion factor. So again, I know this schedule, like this table looks like a little bit complicated, but it's really not once you understand what it says. So again, volume times pressure, that basically the work of inspiration in centimeter water per liter. If you calculate it by the respiratory rate, that would be the power of inspiration. So it's centimeter water per liter per minute. And if you add the conversion factor, you get basically to convert this into joules per minute. Oh, oops. All right, another way of calculating it is just an example, you know. So this is a patient on the volume controlled mode with a constant flow, square waveform. We have the peak here pressure, we have the plateau pressure. So we have a peak of 23 centimeter water. We have a plateau, I'm sorry, I can't see it very good. Anyway, we have a PEEP of 5 here. So it's the total minute ventilation, which is here. The ventilator gives you all the numbers, so it's 5.8 liter times the peak pressure, 23 centimeter water, plus the PEEP 5, plus the inspiratory flow. This is Giosa's equation. Inspiratory flow was 43 liters per minute divided by 6. Then all divided by 20, so that you calculate here that the mechanical power is 10.2 joules per minute. Again, in pressure controlled, again, the conversion factor 0.098 times respiratory rate times the tidal volume times the delta pressure plus PEEP. So you get here respiratory rate 12, tidal volume was, this is in liters, so it was 0.498 times the respiratory rate of 20, the driving pressure plus PEEP. So it comes to 11.71. So basically what I'm trying to say is there are simple equations that you can calculate the mechanical power from the ventilator. The problem is most of those studies are done to calculate the mechanical power when the patient is passive, does not have respiratory effort. So you assume that all the work or all the energy is delivered by the ventilator. Sometimes we forget in the patient who can actively breathing or spontaneously breathing, his diaphragm is working and he's creating muscle pressure or PMOS, if you remember the equation of motion. So how much of this energy is translated here, we're not sure. So you have to, if you want to be accurate, totally accurate, we have to calculate how much is the muscle pressure of the patient. And this is very difficult without an esophageal balloon. But again, for the sake of simplicity, we can calculate the total mechanical power from the ventilator screens. To be honest with you, I don't know how many of you really try to stand and calculate the mechanical power. I try, of course, it's very hard because the patient, we change components of ventilation very frequently. Every time you change the PEEP or you change the respiratory rate or the compliance changes and the pressure changes, it will be very hard. And this changes like very frequent, right? So it will be very hard to stand beside the ventilator and do these equations every time you do a change or every time the patient has a change. So the reality is we need like automatic calculation by the ventilators. The same, we don't try to calculate, you know, like on the now new generation ventilators, it gives us how much peak pressure, how much respiratory rate, what's the inspiratory time. We don't stand there and keep measuring them. So we need something that tells us what is the total power, what's the mechanical power breath by breath. And I put that example here of one the Bella Vista E1000, and they have that software, which I'm pretty sure in the future it will be on most of the mechanical ventilators, that it calculates for you everything, and all what you have to do is just look at the screen and know what's going on. So it gives you the total work, the inspiratory work, and even the tidal work. I don't know if any of you seen that in clinical practice or no. I know this is not approved in the US yet. It's not FDA approved yet. But I'm sure it will be coming in most ventilators in the future, which will simplify really our lives as clinicians standing there. So I want to jump a little bit and go into components, more components of mechanical power. So the idea of mechanical power is the whole energy going to the respiratory system. Again, as we said, the respiratory system is the lungs and the chest wall. So why are we worried about the chest wall? If I have a stiff chest, of course, my compliance will be low, and the ventilator has to work hard to push the air into the lung. But all of this is to overcome my chest wall compliance. We can't probably hurt our chest wall. You're not going to hurt the muscles outside and the ribs. You might hurt the diaphragm, but we're more interested about lung injury, not chest wall injury. So we need to find the components that affect the lung alone. So how can we differentiate between the lung and the chest wall? And I'm sure you all know it, is by inserting an esophageal balloon manometry. And then we can differentiate between the chest wall compliance and the lung compliance. So this is a patient on pressure controlled ventilation, airway pressure up here, flow, esophageal pressure, and that is the transpulmonary pressure, which is basically the airway pressure minus esophageal pressure, and give you that curve, esophageal, that's the transpulmonary pressure. So how to calculate the transpulmonary mechanical pressure? Pretty much the same, again, same idea, which is volume times pressure times plus the PEEP and the respiratory rate. So here's the equation: conversion factor 0.09 multiplied by the respiratory rate. And this might be a little bit different, but it again talks about the pressure times the volume. So tidal volume to the power 2 multiply half multiplied by the elastance of the lung. The elastance of the lung will be the transpulmonary pressure. Elastance is pressure over volume. So it will be the end inspiratory transpulmonary pressure over the volume. So elastance of the lung plus the tidal volume plus the PEEP. Again, a lot of equations and a lot of calculations, but once you have this figured, it's pretty easy to calculate the transpulmonary mechanical power. And again, in my thinking, this is much more meaningful and much more beneficial to understand ventilator-induced lung injury. So 2 months ago, we thought even is like, okay, we're talking about the lung as a whole, even if we differentiate between chest wall and the lung. When we talk about the lung, we talk about, as I mentioned, the resistive pressure of the energy to overcome resistance. But again, when we give the energy, are we injuring the big airways like the trachea, the large bronchi? Probably not. Again, those are cartilaginous things. What are we injuring, or what are we interested in lung injury is our alveoli, because those are the vulnerable unit that open and close, and that's how we can injure it. So we came to the idea is like, why don't we try to get the compliance of the whole alveoli and just remove the wasted airways that the alveoli does not, sorry, the wasted tidal volume that our alveoli does not see. So basically what we did, and that's another big discussion, is instead of using the total tidal volume that all the equations been using, we tried to figure out how much dead space, wasted air, wasted volume, and we tried to use the equations only on the alveolar tidal volume. So again, I'm not going to talk about it too much, but if you have volumetric capnometry, it can differentiate for you that green circle. It's the dead space, VDAW. So this is the dead space that goes into our large airways. And we can differentiate it also into tidal volume, alveolar tidal volume. So this person, for example, was getting 370 milliliter tidal volume. 1/3 of it or more, 146, is dead space, and our alveoli is seeing 214. So this is the effective, actually, alveolar volume that our alveoli can see and can injure our alveoli. So we were able, but to do all of this, I know it might sound a little bit crazy or complicated. We need an volumetric capnometry, and we need an esophageal balloon. And according to this, and I'll show you the reference later if you want to read the article, we can calculate alveolar compliance. If we can calculate alveolar flow, alveolar resistance, then we can calculate transalveolar mechanical power, which is very similar to the equation that I mentioned before. But instead of, so again, it will be the conversion factor times the resistance times the, instead of like total tidal volume, it will be only the alveolar tidal volume. And instead of the whole lung elastance, we're just going to do the elastance of the alveoli, again, times the alveolar tidal volume times PEEP. And here's the equation. Oh, okay. So let's go a little bit now about what is the relationship between the mechanical power and the elastance and the resistance. This is the initial article by Gattinoni. And this graph, he showed what's the correlation between elastance and resistance with the mechanical power. So the percent variation of mechanical power as function of the elastance, which is like the circles here. So of course we know as the more the elastance worsens, the mechanical power will increase. And the squares here are the resistance. The more the resistance increases, the mechanical power will increase. So you find that the variation of the mechanical power with the resistance are lower than those with the elastance of the respiratory system. And that the mechanical power increases by 8% with each 20% increase in the elastance. So the more that the respiratory system elastance get worse, say the elastance, for example, was 40 and became 50, 20%, of course, the mechanical power will increase. If and then it also, the mechanical power will increase by 6% with 20% increase of resistance. This is another one, same from the same article. Now he divides the mechanical power to its components: the tidal volume, the flow, the driving pressure, respiratory rate of PEEP. And what they found is the percent increase of mechanical power as a function of change of volume over delta airway pressure, delta pressure, and respiratory flow. I don't know if you can see really the curve very good, but those are the circles, those are the X's are the respiratory rate, the squares are the flow. The variation of mechanical power with the tidal volume, airway pressure, and respiratory pressure, they all lie on the same curve. So the tidal volume, the flow, the driving pressure are here. The respiratory rate has its own curve, and the PEEP has its own curve. So the mechanical power increases by 37% with any 20% change of both the volume, the pressure, and the flow, this first curve. And it increased by 27% for any 20% increase in the respiratory rate. So the curve is more steeper here, meaning that the respiratory rate actually increased the mechanical power more. And it increased by 5.7% with change of the PEEP. Again, this is from one study, and we tried to, we did some bench studies. I don't think I'm going to talk about it much because we found that actually our conclusions was different from this. But at the same time, this study that Gattinoni did was on the volume control ventilation. We did them on pressure control ventilation. So I'll go to some kind of like questions I always had in my mind. And the point of all these questions is we really don't know everything yet on mechanical power. When you think about it, the idea of mechanical power just came about 5-6 years ago. And now there is lots and lots of research. Almost every week you find new articles about mechanical power. So we're still in our infancy and we still don't understand it fully. And I don't think we should make conclusions or should make decisions that affect the patient on something that we don't fully understand yet. So I put the green as like the check mark as there's some evidence, the question mark as well, there's no evidence yet, and no as no evidence. So does mechanical power is related to ventilator-induced lung injury? And I think in the on the evidence and research that there is good enough research to say yes, mechanical power, the higher the mechanical power is correlated to ventilator-induced lung injury. Same is mechanical power related to mortality, and similar to the top. Yes, there is a lot of research that mechanical power is related to mortality. And during the COVID time, actually, there's a lot of studies that the mechanical power during COVID was so much higher than the mechanical power during non-COVID, just the regular ARDS. We see numbers like in the 30s and or almost 35, which is huge. A question always comes to my mind, which lung is more vulnerable to ventilator-induced lung injury or to high mechanical power? If I have a normal lung and I have another patient with ARDS, and we're both getting the same mechanical power, who can get injured? Is it the normal healthy lung or the ARDS lung? And actually, it's very conflicting, and there's no much research behind it. I'm sure it will come and we'll know. But just based on 2 physiology books, one actually suggested that the healthy lung is more prone to lung injury, but another book said that, probably the already injured lung is more vulnerable to injury. I don't know the answer. As I told you before, is the total respiratory mechanical power or more important, or the transpulmonary mechanical power is more important? And there is few studies, maybe 2 that I know about, that showed that in their conclusion that the total mechanical power didn't alter mortality, but it's the transpulmonary mechanical power that is more dangerous to the lung. And as I mentioned now before in the previous slides, maybe it's even we should look at the alveolar mechanical power. But of course, this is a new concept and there is no evidence for that yet. As I mentioned before, is indexing the mechanical power more important than looking at the total mechanical power? Maybe some evidence that yes, that if you index the mechanical power to the compliance or the elastance or the ideal tidal volume per ideal body weight, or even to the aerated area in the lung, might be actually more meaningful than talking about mechanical power. So somebody getting mechanical power of say 20 joules per minute, but compliance of 20 might be different from, again, somebody getting mechanical power of 20 joules per minute with a compliance of 50. Again, few studies that talk about this, maybe 2 or 3. I mentioned before about the alveolar mechanical power. We don't know what are the components of the mechanical power that are more important. We talked about the elastic one, which is the PEEP and the tidal volume. We talked about the resistive. Should we even bother by the resistive mechanical power? Should we bother by the PEEP power? John Marini talked about this a lot. It's very interesting to hear the talks or read this articles that talk about this, but for now we don't have much evidence. How about auto-PEEP? A lot of times the patients are having auto-PEEP and we calculate our mechanical power based on the PEEP alone, so we don't know. Again, should we target a certain number? I don't want to go into this in details, but we used to like get into that trend of patient has to be in 6 milliliter per kg because that improves mortality. Patient has to be on less than 15 driving pressure to reduce mortality. Again, we have to understand that, you know, it's not always the lung, there's chest wall and stuff like that. Each patient is different, so I don't know the answer, but if you ask me, I don't think we should target a certain number, but it should be individualized, a patient to a patient. Again, measuring the mechanical power, what's the best way, what's the best equation, how can we calculate it? Passive versus an active patient, we talked about that, how can we calculate the PMOS? We talked about automatic measurements, which I think will make our life much easier. And now the important actually question is, our closed loop modes are better than reducing mechanical power than our regular conventional volume control and pressure control modes. And probably yes, there's a lot of studies now. The closed loop, by those I mean the intelligent modes like ASV and AVM. There is a lot of studies about ASV, and we did 2 bench studies comparing the AVM, adaptive ventilator mode, excuse me, to conventional volume control on PRVC, and we showed that actually AVM reduced the mechanical power. And right now we're doing actually a study in our ICU comparing pressure control to volume to AVM closed loop modes to see if the mechanical power is better. Again, I think I talked about this, and I'm probably running out of time. I don't want to hold you up too long. Same things we talked about. I put this in some social medias. Our mechanical power is same in volume control and pressure control. You know, so I put this guy in pressure control, this guy in volume control. It's the same mechanical power, but is there a difference? Are they the same or not? We don't know. Again, this is a passive patient, and this is an active patient. This is simulator work. It's hard to calculate this in real life, but this is in simulator. So they're both getting the same mechanical power, but this guy is passive. The ventilator is doing all the work versus this guy is active, and you can tell here by the change in the airway pressure. Are both the same? Both vulnerable to the same mechanical, to lung injury? Again, we don't know. Another one here, same mechanical power, but different ideal body weight. So the mechanical power to compliance index is different. So this guy who's skinnier or lower ideal body weight is getting actually higher mechanical power compliance index compared to that person who's having higher ideal body weight. Again, we talked about the transpulmonary mechanical power. So those are 2 patients here. Total mechanical power is 24.6, but when you have esophageal balloon and transpulmonary pressures, we calculated the transpulmonary mechanical power, and you can see that this guy on the left has higher transpulmonary mechanical power compared to that guy on the right. So despite both are getting 24.6, without an esophageal balloon, we will never know that they are not the same. Okay, so what are we going to do at the bedside? That's my suggestion. Basically, you have to make sure everything is low as possible. So yes, we have to use the lowest respiratory rate because again, it's really correlated to the mechanical power. Of course, we have to use the lowest tidal volume. I'm not a big advocate of the 6 milliliter per kg, but again, the lowest tidal volume that you can do, it will be better to know how much dead space. So you need to know the alveolar tidal volume if you use the volumetric capnometry, and of course the lowest driving pressure possible. You have to use the adequate PEEP, and that's another huge conversation and debate. You can go. It's been 50 years, and we don't know what is adequate PEEP mean even. I really use esophageal balloons a lot, especially in the difficult patient, because I get so much information from it. I can calculate the transpulmonary driving pressure. I can just calculate the lung transpulmonary pressures instead of the chest wall. What can you do if you feel that you're using very high mechanical power? Of course, prone position might improve the heterogeneity of the lung and might reduce, you don't have to use very high driving pressures to inflate the lung. Sometimes adequate sedation to reduce the pleural pressure swings and the transpulmonary pressures and try to reduce the synchronies might help with the mechanical power. Those are some of the references, the Gattinoni and Giosa and Bescher, the ones that we talked about, how to calculate the mechanical power. This is the one, also very nice article actually talks about how to minimize ventilator-induced lung injury. This one talks about the effect of mechanical power and mortality, as we talked about. This is by Arnall about mechanical power in closed loop modes like IntelliVent ASV. Those are the two studies that we did in our bench studies about comparing AVM, another closed loop, versus conventional ventilation. This is a very nice review also by Shadburn and Van der Stey, talking about mechanical power and optimizing ventilator-induced lung injury with the new closed loop ventilators. This is a very nice review also by Marini, if you want to dig in deep into that subject, evolving concepts of safer ventilation. And this is the one that we're talking about, alveolar mechanics, that we just published a couple of months ago. With that, I'm going to stop and say thank you to you all for having me. And again, sorry that if I was late.
Many thanks, Prof. Ehab, for this nice lecture about this difficult topic, which I think is become slightly or more or less clearer than previously. If we have any questions from the candidates, we are happy to hear from you. And I can start with a question from me. It's asking about is there are another ventilator trademark measuring mechanical power outside the Bella Vista ventilator?
You know, I'm not aware of that. I want to say I'm sure you know, just give them a year or two, because it's a copycat business. Every, you know, it will be there. I don't know. Are you aware of any? I don't know.
Okay, I will search for them and I will give you a feedback, inshallah. Another question for me, Bardo, does mechanical power in spontaneously breathing patient is accurate? It may be variable from breath to breath. How can I take the average, or how can I deal with this situation?
That's an excellent question. Again, the whole idea is, I don't think with the spontaneous breathing you will be able to use the equations, all these equations. I think the best way is to, if you plot the pressure volume curve, and you really are good in math, or and calculate the area under the pressure volume curve, the integral of the pressure and the volume, and multiply it by the respiratory rate and everything. I think that's probably the best way of measuring it. That's actually the gold standard in calculating the mechanical power, is the integral of the pressure volume curve. All those equations, as you mentioned, like, you know, you don't know how much muscle pressure is involved in that equation. So by the equations, I don't think you'll be able to do it. But that ventilator, that software that we talked about, the way it gives you the number, it actually calculates, the computer calculates the integral of the pressure volume curve. So I think that's probably the best way.
So is there a role for transpulmonary pressure these continuous breathing patients, using transesophageal balloon to measure, to target to reach an accurate measurement of the pressure muscle?
Yeah, man, you have very good questions that you know, I think it is the best way. Well, first of all, to calculate the PMOS is the only way that I know is like to use an esophageal balloon. There are the unfortunate problem is almost less than 1% of clinicians around the world use esophageal balloons because it's cumbersome, you know, whatever the reason. There are surrogates for the muscle pressure if you don't have esophageal balloon, like you can use another ways to try to, you know, obtain the muscle pressure, like the P0.1. There's another software, like say in Medtronic and during the PAV, that try to give you the muscle pressure and stuff like that. But I think you are right. You need to have an esophageal balloon, yes, to calculate the PMOS of the patient and to calculate the transpulmonary pressure. So without it, you're not going to be able to do that. Yeah.
Many thanks, Dr. Ehab. We have a question from Dr. Muhammad Amin. He's asking about, is there any cutoff points, even in small trials, to target or avoid or even in some population like ARDS or other, or just a matter of trends to follow up in each patient?
Great question too. You know, you started seeing, you're probably all aware of those studies that that compared mechanical power and showed, I remember one, I can't remember the exact, I think it was 15 or 17 joules per minute. And above that, the mortality was much higher than less than that. So they took that to cut off. In other studies, again, in COVID, I saw numbers as like above 25 or 27 was the mortality was higher. So I think we will know more as the years come. And that's why I was always very, very cautious to try to target just a level, one certain level. I think it's all trends. And the idea is you try as much as you can by reducing, tolerating the lowest mechanical power that you can get. So if you're trying to reduce the tidal volume, the respiratory rate, the driving pressure, all of those things, and now your patients, you know, minute ventilation is like 3 and your pH is 6.9, and well, you know, you can't do that, of course, right? So you will have to go up on the, you know, optimize everything. But I think the idea is, again, every patient is different than the other patient. We used to always put ARDS patients are like the same, but we know that they're not the same, right? According to the etiology, it could be different. If I have ARDS today from trauma versus somebody else has ARDS from pneumonia or shock, our respiratory mechanics are not the same. Even if I have ARDS today, my lung might be recruitable and stuff like that. 2 days from now, I'm still with ARDS, but I'm not the same respiratory mechanics. My lung now is not recruitable. So it's really very complex problem. And, you know, we tend again to put all ARDS in one basket and say, oh, mechanical power in ARDS. But I don't know the answer to this, you know, honestly, it should be individualized patient by patient.
Okay, we have another question by our friend, Dr. Amr Farag. He's asking about that these indices are unreliable in cases of open chest, like those after cardiac surgery, and also in patients with very low tidal volumes and severe ARDS.
Is the mechanical power unreliable in open chest, right? So if you're able to calculate, so usually in open chest, you know, especially during anesthesia or something like that, you know, you're basically eliminating the chest wall compliance. You're basically only probably dealing with only the lung or the transpulmonary pressure. I would, you know, so you probably would need to have, you know, like target certain numbers because now you again eliminated the chest wall. I don't think there's any studies about mechanical, at least that I'm aware of. There might be, again, every day now there's a new study about mechanical power. I'm not aware of, like, you know, in only in situation of open chest. Sorry, what was the second part of the question, Rahman? I already forgot.
It was about patient with very low tidal volumes, from 4 to 6 ml per kg.
Yeah, yeah. Well, we always, you know, as you said, the lower the tidal volume you will use, the lower the mechanical power would be. You know, the higher the volume, the higher, and subsequently, of course, the pressures, both will increase or decrease when you change the tidal volume. You know, again, to be honest with you, if we don't know how to diagnose ventilator-induced lung injury per se with, like, say, biomarkers, we will never know what's the relation of, you know, say, mechanical power is 15, now we went to 20. Is that increased by 5? Is that causing ventilator-induced lung injury? So as long as we don't know even how to diagnose it, you know, I don't know we're gonna ever get like answers of like relation of, you know, mechanical power to ventilator-induced lung injury. I mean, we know that a lot of events happen during the ICU. You can get pneumonia, and of course, you know, your mechanical power will need to increase and stuff like that, and the mortality might worsen. But is that worsening because of the mechanical power or because of pneumonia? You know what I'm trying to say? So again, we don't know how to diagnose ventilator-induced lung injury, and that's a big problem. So as long as we need to know how, we have to have a gold standard to diagnose it, and then put it in the relation with the mechanical power, and says like, yes, above this level, like, you know, our risk is increasing, or it doesn't matter at all. I don't know the answer there.
Yes, yes, Dr. Ehab. Another question asking about there is a relation between mechanical power and bronchodilation, and also with high abdominal pressure or abdominal compartmental syndrome.
As you said, if the patient has high resistance, and we're calculating the whole total mechanical power, and if you give bronchodilators and your resistance drops or improve, of course the mechanical power will improve. In abdominal compartment syndrome, you know, of course, you're dealing with not lung compliance and chest wall compliance. So if you're able, again, to put the esophageal balloon and calculate only the lung compliance, there is some evidence that, you know, then you can calculate the transpulmonary pressure or the transpulmonary mechanical power, you know, to again, to like just isolate the lung from the rest of the abdominal wall. I am aware of one study that showing, I think it was very small or case series of like increased abdominal compartment syndrome, and you know, it's of course the total mechanical power was worse. Again, is that related to mortality? Is the mortality related because of the mechanical power is high, or because of the etiology, what's causing abdominal compartment syndrome, or whatever is going on in the abdomen per se, you know? Again, I apologize because most of my answers will be basically come to like, I don't know yet, or we don't know yet.
You can continue, Dr. Ehab, you can continue.
Oh yeah. No, I was saying, like, you know, again, it's one of those things that we totally don't understand. You know, by increasing, like, if somebody has abdominal compartment syndrome, and of course your pressures have to increase, so your mechanical power increases, just to inflate, to overcome the chest wall elastance. Does that hurt the lung or no? I'm probably not. You all put, you know, before, like, you know, you if you use esophageal balloons like enough, you would see, you know, and your driving pressure, you know, it's like, say, 30, and people tell you, you're crazy, you're using very high driving pressure, you're correlating, you know, worsening mortality, we shouldn't use above 15, right? But if you do, like, you have driving pressure of 30 and your pleural pressure is like 15, 20, 25 because of the abdominal compartment syndrome or the chest wall, your transpulmonary pressure or the lung pressure is actually very low. So that's why I'm saying it doesn't matter what's the driving pressure for the whole respiratory system. It just, you should always look at the lung alone. So.
Many thanks, Dr. Ehab. And can we end with the last question? And I asking you about if we want to apply the concept of mechanical power at the bedside, how can we start? Which patient to use? If there is any benefit to use it in the clinical side, outside the research.
Yeah. I think yes. You know, especially if nowadays we're more aware about ventilator-induced lung injury, and we've been over the last 20 years. Again, we're like trying to reduce the tidal volume, trying to reduce the plateau pressure, trying to reduce the driving pressure, because we want to reduce the ventilator-induced lung injury. So I think nowadays with the mechanical power, if we can apply it basically to each patient, each intubated patient on mechanical ventilation is prone to have ventilator-induced lung injury. And I think we should apply it to the bedside, especially if you can use the simplified equations, you know, or when those software come, you know, which gives it to you, like, you know, the mechanical power. I think we should apply it. We should learn more. We will learn more clinically on, you know, what's our effect, like if I reduce the respiratory rate, how much I reduce the mechanical power, if I reduce the PEEP, the flow, and all this stuff. So I think it's very important to really start looking at this and use it in our daily practice.
Many thanks, Prof. Ehab, for this nice lecture and this nice discussion. Hoping that we are all now clear about this concept of mechanical power, and hoping to see you all in the next webinars by our Essentials group. Many thanks, Prof. Ehab, and many thanks for all the candidates who attended our webinar today.
Yeah, again, thank you so much for having me, Dr. Abdurrahman, and my pleasure. And again, I apologize because you
never
get
mind,
old and your brain.
Never mind, we are in time. Don't worry.
Okay.
Many thanks all, and we can now finish our webinar. The recording will be available on the YouTube channel, inshallah, within 2 or 3 days. We will send you by email the link for our YouTube channel to revise the 2 lectures done today. Thank you all for attending till the end with this too busy day, and many thanks for our Prof. Ehab Dawood for his kind lecture today, and for Prof. Muhammad Amin for his nice lecture. Many thanks for all you.